This is Chapter 25, The Child with Cancer, Part 2. Leukemia is our most common childhood cancer, and this is considered a cancer of the bone marrow, the hemopoietic cells that make blood. That is where the cancer is, where the problem is. So they're starting to classify leukemias in a number of different ways, but the most basic of the classifications are AML and ALL. And of the two, ALL has better survival rates. Actually, they both have pretty good survival rates. We've come a long way in treating leukemia, but ALL has better rates than AML. And just kind of to note, kids with Down syndrome, trisomy 21, have a 20-time greater risk for developing ALL. So here's a cute little guy who had it and kicked it. So the pathology of leukemia is an unrestricted proliferation of immature white cells. So the bone marrow is going crazy making white cells, but they're not good white cells. They're immature and they don't work well for fighting infection. So there's no actual tumor, but it kind of presents like other cancers. So we do get damage done to the liver and the spleen, and that's because we get all those leukemic cells can infiltrate and do damage, and then we're going to see the anemia and lowered white count of mature cells, lowered counts for platelets, because all of the elements needed for making blood cells are being used to make these ineffective immature WBCs. So we're going to see high immature WBCs and everything else is going to be low. So and this is what I just said, we're going to see anemia. We're going to see infection because we're going to have the low white cells, the neutropenia, and we're going to be at risk for bleeding because of the reduced platelets. And then the spleen, liver, and lymph glands all can get enlarged and engrow because they become infiltrated with those leukemic cells, and then it can firm up, kind of fibrose, become hard. Leukemia also is known for invading into the central nervous system, so they'll do a lumbar puncture to look for leukemic cells in the cerebral spinal fluid. The main diagnosis, we start out looking at that CBC, and then the definitive diagnosis requires a bone marrow aspiration, and then they look at what the bone marrow is doing, because that's the problem. And this is how a bone marrow aspiration is done. We'll put Emla cream and totally numb the site, and then along the iliac crest here, puncture down with a rather large needle, big enough and strong enough to break through the bone into the bone marrow and aspirate out the bone marrow. And then that's what they're looking at for an actual definitive diagnosis. So when we do have diagnosis confirmed, there are 4 phases we're going to do of chemotherapy. First, induction therapy, 4 to 6 weeks, and this is trying to kill off that bone marrow that's making the abnormal cells. And if we need to, if there is infiltration into the CNS, we can do some chemotherapy into there. Intrathecal is to actually insert it into the spinal fluid. And I've not seen that necessarily done prophylactically, but evidently it can be. And then intensification. This is, we've killed off most of the bone marrow, and now we're trying to eradicate the little bit that's left that stays. And then from there to maintenance therapy. Our hope is that if we can kill off all of those cells that make those hemopoietic cells that make the blood cells, then let them regrow, that it's going to be normal ones that make normal cells that will regrow. And in ALL, often the person that will work, they'll go into remission through this first cycle of chemotherapy. AML, it's a lot less common for us to be able to kill off those abnormal cells and then the person's own normal hemopoietic cells regrow. So in AML, the first time they get somebody into remission where they're not making any leukemic cells, we may try a bone marrow or stem cell transplant. In ALL, they'll usually try and kill off all the person's bone marrow and let it come back, because there's a good chance what comes back will be normal. So they usually won't do that transplant as early in ALL. Because when you do either bone marrow or stem cell transplantation, this is a cure or a kill. We killed off the person's normal bone marrow, and now we're hoping that they will engraft that from a host and start produce that will reproduce and fill their bone marrow, and it will start producing blood cells. So if they have a reaction to it, they will pretty much die. And that's graft versus host disease. If they react to it, their immune system is gone. I mean, they really can't do anything. We've killed off pretty much all of their own natural blood cells, right? So they're dependent on getting blood transfusions, but if they get an infection, it's going to be an overwhelming infection because we have killed off everything. If they go into organ failure, have organ damage, it's going to be very difficult to do anything. So it does say we can, that we see a cure when we do hemopoietic stem cell transplant in 60 to 70% of the cases. But if you relapse, they occasionally will try a second time, but usually not. Usually the prognosis is really very poor if the stem cell transplant doesn't work. So some things to consider. We're doing painful procedures on these kids. So preparing them before things we do, and then doing them in as pain-free of a way as possible. Leukemia is painful. Cancer is painful, and half of the treatments we do are painful. So managing pain. And then we're making them immune suppressed. So treating that and treating infection control. And we're going to be giving them these chemotherapy drugs to stop their bone marrow from producing abnormal cells. And that also makes them just sick. So nausea and vomiting, anorexia, they don't want to eat, mucosal ulcerations. The chemotherapy drugs kill the rapidly maturing cells, which includes all the lining in the mouth and the gut. Neuropathy, some of these can stimulate nerves that transmit pain. Hemorrhagic cystitis, this is bladder irritation. Alopecia, losing their hair. Mood changes, especially from those steroids, and moon face also comes from the steroids. So just some common nursing diagnoses you want to keep in mind. Risk for injury related to the malignant process and also related to the treatments. Risk for fluid volume deficit from the nausea and vomiting. Altered nutrition, impaired skin integrity, altered family processes, especially we have kids from 3-4 hours away, so you can imagine how much that impacts the family. Fear related to the diagnosis, the procedures, and the treatments. So that's our leukemias. moving on to lymphoma. Lymphomas are a cancer of the lymphoid tissue. And then if you have Hodgkins, it's in the lymph nodes, and if it's non-Hodgkins, it's more widespread, and then these metastasize out to non-nodal tissues. Usually what you'll find in Hodgkins is painless enlargement of the lymph nodes. They don't hurt, they're just enlarged. And this is mostly in our teen population. And then non-Hodgkins is more common in the a little younger. And with Hodgkins, it tends to be isolated to a specific group of lymph nodes, where non-Hodgkins, it's much more just diffuse or widespread. But they both have very good survival rates, like 90% or better. So with Hodgkins, it starts in that lymphoid system. If it does metastasize, it's often to spleen, liver, bone, marrow, lungs, other tissues. And then again, what we said is asymptomatic enlargement of the lymph nodes, often cervical or supraclavicular. So if you think your neck and up above your clavicle is where it usually starts. Sometimes cough, abdominal pain, or anorexia, but usually no symptoms. And here's just little groups of lymph nodes, right? You have lymph nodes really through your whole body, but there's some areas that are just more dense with nodes than others. So there's a little schematic of that. So with Hodgkins, they use radiation and irradiate the area that has it, and then chemotherapy to cover everything else. Again, prognosis is really good. Some of the things we do want to think about is preparing the child for both diagnostic procedures and the side effects and the things from the treatment. And with non-Hodgkins, it's more common. So 60% of our pediatric lymphomas are non-Hodgkins. So this doesn't have a specific area of lymph nodes. It's much more diffuse and more poorly differentiated, more disseminated. So what we're going to do with that, we treat it very similarly, except you can't stage it the way you do. So we're still going to irradiate areas where we find those lymph nodes, and then we're going to be giving chemotherapy because this one is more diffuse. But again, even in advanced stages and disseminated disease, excellent survival rates. Transfusions. All these kids, we are needing to give them transfusions. Partly cancer makes you anemic because the tumor or the cancer takes up all of the elements that you normally are using to make blood. And then when we give you chemotherapy, we stop you from making blood. So you're going to be extremely anemic. So we have to give transfusions. The worst and most life-threatening kind of reaction is a hemolytic reaction. So this, right, hemolyze, break apart blood cells. It's very severe. It's very fast. Fortunately, it's very rare, but that will kill you really quickly. Our more common is ABO incompatibility. Remember on your blood cells, you checked in physiology probably your ABO. So if we have incompatibility between the blood types, right, A and B are proteins on the blood cells. O means you don't have either A and B, but there are 100 other proteins on the blood cells that are just not quite as many as the A and B, but there are other things that you can react to. So reacting to those. So what we usually see are fever and chills. You can have an allergic reaction to some of the preservatives that are put in the blood, and that will usually be itching or some hives on the skin, that sort of thing, but can have swelling in the airway. Be careful if you're giving blood fast in a trauma. You can get an air embolism. If you don't warm the blood, you can give them hypothermia. And by giving too much blood, we can throw their electrolytes off because they're getting all those electrolytes particularly hyperkalemia, potassium especially, right?